for all part of the online program. And this program provides us an opportunity to really go wide in terms of coverage of pediatric endocrinology. The uniqueness of this program that is that it is specifically targeted for pediatric endocrine issues related to postgraduate trainees. And this is something which really makes it a very good program. A lot of interactive sessions have been happening. They are all available on the YouTube, so all of you can have a go and have a look on that. And I'm sure this is going to be a wonderful program. PEP really aligns very well with the motto of ISPAE, which is towards spreading pediatric endocrine knowledge. The quality of care needs to improve, and we hope that this session will go a long way in improving the same. Over to you, Dr. Javinder.
Thank you, sir. Thank you, sir, for your kind words. So, unfortunately, Dr. Raghupati has not joined us due to some issues. So, now we will be starting the first case. So, we will be discussing a common disorder which is frequently seen in the pediatric training. So, it's a rickets. And first case is a case of nutritional rickets. The case would be presented by Dr. Pavitra Shah. She is third year MD resident at SGRR Institute of Medical and Health Sciences. And she has been guided by Dr. Ashish. And Dr. Ashish Sethi is Associate Professor at SGRR Institute of Medical and Health Sciences. So over to Dr. Pavitra. You can start sharing your slide and present your case. And the examiner for the first case is Professor Mahesh Maheshwari. So Dr. Maheshwari is the PG examiner and is the author of many chapters and uh, publications. And he is in charge of pediatric endocrinology services at AIMS Bhopal. And he has started DM endocrinology, pediatric endocrinology program at AIMS Bhopal, and he is in charge of this program. Over to Dr. Pavitra, Dr. Ashish, and Dr. Mahesh, please.
Am I audible, sir?
You are audible.
Thank you so much, sir, for your introduction. It's my extreme pleasure to be presenting on these platforms. With your permission, I would like to begin the case, sir. I'm sharing my screen.
Yeah, yes, please.
Yeah, Dr. Gupta.
So, Dr. Mahesh, we have some PGs who have joined the session. So, you can stop her in between if you want to clarify something or if you want to ask. So, we want it to be exam oriented as far as possible.
Sure. I think Dr. Pavitra, you can start and then we will go ahead with that.
Thank you so much, sir. I'd like to begin my case presentation under the guidance of my associate professor, Dr. Ashish Sethi. Um, so my case is a case of a 16-month-old toddler male child who's a first order born out of a non-consanguineous marriage and a resident of Dehradun. The history was given by the mother, who is educated up to 8th standard, and the history was reliable. The child was brought with complaints of outward bowing of both legs for the past 5 months. The child was apparently normal until 11 months of age, when the mother noticed progressive outward bowing when the child began to stand. Deformity gradually worsened over the last 5 months, and the mother did not notice any obvious short stature, widening of wrist until she was informed post evaluation in the current admission. The mother had not appreciated any patchy or excessive hair loss, any visual problems, yellowish discoloration of eyes, hearing difficulty, or abdominal distension. There was no history of any bone pains, fractures, seizures, any frequent urination, frequent loose stools or large bulky stools, any history of
Just a
drug
minute, Dr.
intake.
Pavitra. Just a minute. I think you already started with the negative history or the history, so you already made up your mind for a particular diagnosis, because whenever you start taking a negative history, we usually start thinking a probable diagnosis. So till now, I think whatever the presentation you given, the only complaint is bowing of legs. So what are the different differential diagnosis came to your mind? This is the reason you thought about asking all these particular questions.
So considering the age of the child, my first differential was physiological bowing, sir. Since the child is 16-month old, followed by so the most common in our country, that's vitamin D deficiency. So nutritional rickets was my second differential diagnosis, sir. Uh, Followed by some my negative history included frequent urination, frequent loose stools, and large bulky stools. Frequent urination, polyuria was to rule out renal disorders, and frequent stools and large bulky stools to rule out malnutrition. So drug intake was to rule out if the child is on any anti-epileptic or any anti-tubercular drug that's causing a vitamin D deficiency in the child, or any chronic systemic illness like CLD or chronic renal failure that's requiring hospitalization in the child. So, recurrent fractures and bone pain was for osteogenesis imperfecta, and seizures was for the
So,
drug
Dr.
histories.
Pavitra, my only concern is at this point of time, because you're
Yes.
presenting complaint, chief complaints, like you said, and the history of present is not really suggestive that at this point of time you need to start thinking about a non-nutritional rickets or some other causes related with this. So at this point of time, you are having only bowing of legs. That is only one complaint that you had. So probably at this point of time, I feel this history cannot be usually think of. So in the history of present illness, we can just go ahead with the other causes of bowing of legs. So is there any family history, or is there any? So that is more important in that point of view. So you can go ahead with the case further.
Okay, so I would like to begin with the antenatal history. The mother was a booked pregnancy with no antenatal complications. The mother took iron, folic acid, and calcium supplementation, and she was a booked case at a government hospital in Dehradun. She delivered the baby, who was a term SGA baby with a birth weight of 2.435 kg. The baby was born by LSCS in view of non-progression of labor, and there was no NICU stay or any jaundice in the baby in the initial days, and the breastfeeding was established within 1 hour, and the baby was exclusively breastfed until 8 months of age. The baby was exclusively breastfed until 8 months of age, and complementary feeding was started at 8 months of age, which is by say delayed, sir. So till 16 months presently, the baby is being breastfed and also consumes diluted cow's milk with water ratio with water, the ratio 1:1, sir, and there's also added sugar. There is no history of any egg or seafood or any vitamin D supplementation that has been prescribed since birth, or there's no history of consumption of fortified milk. Developmentally, developmentally, the child is age appropriate until 1 year of age, and the social and the language milestones are normal. The fine motor milestones are normal as well, but there's a mild gross motor delay where the child is able to stand with support, walks with one hand held, and creeps upstairs. Uh, However, the child at 16 months of age is not walking independently, and the DQ is 81, sir, with other domains being normal. The socioeconomic history. The family is a nuclear family of three members, and the father is a rickshaw driver who is unskilled. The monthly income of the father is 10,000. The mother is educated only up to 8th standard, and they're living in a 1 BHK urban dwelling, and they fall under class 4, upper lower middle class, as per Kopusami scale. So the dietary history of this child shows a significant deficit of 470 kilocalories, sir. The child consumes only 600 kilocalories per day, out of which predominantly are breastfeeds with a protein of 12 grams, sir. Immunization and family history. The child is fully immunized per age as per NIS. The BCG scar is visible, and the last immunization was done at 9 months, which is up to date. The MCP card was available, and the immunization history was cross-checked. There's no family history of any similar deformities. There's no family history of renal or liver disease, and there's a low socioeconomic status. To summarize the case so far, as per the clinical history, this is a 1 year, 4-month-old toddler whose first order born of a non-consanguineous marriage, who has had history of 4 months of outward bowing of legs. And historically, I found no evidence of alopecia, any dental abnormalities, or recurrent fractures. There's no history of any systemic illness, chronic drug intake, or any family history of similar ailments. The dietetic assessment revealed a calorie deficit. That showed a lack of established complementary feeding and no vitamin D supplementation since birth, though the child is fully immunized according to NIS. Given this history, I have identified nutritional rickets as the most probable cause with malnutrition, and I would like to proceed with a physical examination to confirm this diagnosis.
Is there any pointers at this point of time that suggests a non-nutritional rickets?
Uh,
And what are the positives that you are able to get to say that this is a nutritional rickets?
so this is a table that I have compiled. So my first provisional diagnosis was nutritional rickets, where the supporting diagnosis was that there was no vitamin D supplementation. There's inadequate complementary feeding, most probably accounting to nutritional rickets. And second provisional diagnosis was a physiological genovarium that occurs in less than 2 years of age. So,
Okay.
and
Anything else in
then,
favor of rickets? Anything else
so,
in favor of rickets? I think in
mm,
your antenatal
the points, so the deformity that I've included it after the examination. So,
no, in a perinatal history, you said that your child is a low birth weight. Is it
yes, it does account to risk factor for vitamin D deficiency.
so that may be one of the risk factors that will be there? And you
Yes,
said there is a significant nutritional history that is important.
yes, sir.
So in nutritional history, what is your interpretation?
So in nutritional history,
Because
there's
the
a
child was,
significant.
and the other thing is that child was exclusively breastfed till the age of 8 months.
Yes, sir.
So will that suggest support your diagnosis of nutritional rickets?
So maternal vitamin D deficiency could contribute to it because since the baby was exclusively breastfed without any vitamin D supplementation, and since the mother also comes from a low socioeconomic status, uh, it's a high probability that it's a nutritional rickets.
Okay. Okay. Take it. Continue.
So, just summing up the provisional diagnosis at the end of our history, we have already discussed why this could be a nutritional rickets and physiological genovarium because the age could, I mean, the child could fall under physiological genovarium. But the point again is the systemic signs of undernutrition, which I'm going to eventually see in the um, examination. A third differential diagnosis, even though rare in this case, could be renal rickets. The only point supporting is the bowing deformity. However, as we have ruled out in our negative history, there's no history of polyuria or any growth disproportion or any metabolic acidosis, any chronic kidney disease in the child, any hospitalization, or any signs of renal function mentioned by the mother. Uh, for diagnosis, I think the rarity just keeps going down, which is hyperphosphatemic rickets. Again, the supporting feature is only the deformity that is early bowing, and points against it is there's no family history and there's severe nutritional deficiency present. And the last and the rare one is skeletal dysplasia. There's deformity is the only supporting factor, but there's no parapheresis, no kyphosis, no family history. And Blount's disease is usually because of the obesity and the weight bearing of the child, but we know that the child is undernourished, so mostly the child is going to fall under malnutrition. And I think as we proceed in the anthropometry, it is just going to support the diagnosis.
Okay.
Uh,
So I think at this point of time, there are so many differential diagnoses though you made, although there is no history suggestive for those particular diagnoses. So
yes, sir.
just for the, I think it is really not needed even in the PG exams to make as many as differential diagnoses if you're not having. So on the basis of history, I think till now you are able to say that there is a possibility of physiological bowing, or there may be a possibility of nutritional rickets. That is the second thing that you can keep. And the third possibility is the Blount's disease that you can keep. But again, definitely the weight is, the history is not suggesting on that way. So preferably I will keep it as only two diagnoses at this point of time instead of going further and keep making many more differential diagnoses. If something I will get on clinical examination, then maybe I will include those differential diagnoses once my clinical examination get completed.
Dr. Mahesh, can I ask one question?
Yeah, sure, sure.
Uh, so, Dr. Pavitra, what history will you take which will suggest that the child has malnutrition? So, can you deduce from your history that this child is having malnutrition?
Um,
So, you said only
mm,
that the caloric and protein deficit is there. So, are there any other clues from your history which suggest that this child is malnourished?
so, considering history suggestive of malnutrition, so history of lethargy, poor feeding could be suggestive of anemia, so in this child. Reduced activity, not playful, lethargic.
Mhm. Or what other specific history we usually ask when we are screening the child for malnutrition? So you have asked about the deformity, you have asked about the vision of the child, whether the parents feel that the child is having any paleness, activity you have talked about the child, and whether the child is difficult to handle or if the child is very cranky, because sometimes in vitamin C deficiency, the child is very irritable on touching, or whether walking is restricted or the child's activities are restricted. Is there any history of any edema feet or edema in or swelling of limbs? So that should be specifically asked. Or hyperpigmentation, you can ask.
Yes.
So you can continue, please.
Moving on to general examination, the child was examined while the child was sitting on the mother's lap, and the child was conscious and playful, and the child appeared undernourished. There was pallor present, however, there was no ictus, clubbing, lymphadenopathy, or cyanosis. Vitally, the child was stable with a heart rate of 110 per minute with regular uh, pulses, no radiolated delay, and there was no any specific character of the pulse. The respiratory rate was normal at 30 per minute, and thoracoabdominal breathing. The baby was afebrile, was maintaining a saturation of 97 on room. Moving on to the anthropometry. So this is the anthropometry chart, and like the nutritional history, the anthropometry chart complements it with the child having a weight of 7 kg at 16 months of age, which is severe underweight and falling below -3 standard deviation. The same thing, the height of the child is 72 centimeter, which suggestive of severe stunting, and it's falling under -3 standard deviation. The height age is 9 months, and the weight age is 4 months for this child. The head circumference of the child is 47 centimeter. That's at 50th centile for 16 months of age, and the weight for length is suggestive of moderate acute malnutrition, falling under -2 ST to -3 ST. These are the anthropometry parameters. Like I had shown in the flow chart, the weight for age is 7 kg, suggestive of severe underweight. The length of 72 centimeter at 16 months of age, suggestive of severe stunting. Weight for length was between -2 standard deviation to -3 standard deviation, which was suggestive of moderate acute malnutrition with the MUAC of 12 centimeters supporting MAM. The upper segment lower segment ratio was normal for age, which was 1.3:1, and the head circumference was at 50th centile. On head to toe
So,
examination,
Dr. Pavitra, can you just go back on your this anthropometry slide? So, what is your interpretation on this slide that you already written? This child is actually having a severe underweight, and there is a severe stunting. So, what happened in a nutritional rickets? Is this linear growth that is more affected as secondary to vitamin D deficiency, or is the weight that is primarily affected?
so the linear growth is more affected, and the weight is affected due to other nutritional deficiencies.
So there may be a possibility the calorie deficit
Like
what
I'd
he had
mentioned in
probably.
general examination, there is pallor, so
Uh,
there is underlying anemia, so
so
probably
with the
secondary
weight,
to iron deficiency due
so
to.
with weight for length, it is still coming in the moderate acute malnutrition. You agree on that?
Yes,
Okay,
yes, sir.
okay, okay.
Thank you. I'll proceed. On head-to-toe examination, there was frontal bossing present, parietal bossing was present. The child had Biden wrist with rachitic rosary. Harrison's sulcus was present. Pod's belly was present. The abdomen was distended. A genovernon deformity was present. There was no bony tenderness or no kyphoscoliosis. Um, on oral examination, two upper and two lower incisors were present. There was no dental caries or any enamel hypoplasia. Angular stomatitis was present.
Okay, so in
The
dental development also, you said the development is normal.
normal, sir.
Other,
There was no
so
dental. No, sir. There was no dental.
so dental caries is more common in your nutritional rickets, or there is a delayed dentition is more commoner in
So
nutritional
delayed.
rickets?
So dental caries are more common.
Okay. Just wanted to know about because your clinical features is really suggestive of there is a severe it's a florid rickets. There's a frontal bossing is there. There's a widened wrist, rachitic rosary, Harrison sulcus. That suggests that this child is having a florid rickets. Okay, and there's a pot belly is also there. But if you see, I am not very sure about this X-rays of that child only, because this child is not looking pale also in the initial clinical examination, but there may be a pictorial difference that can be there, because picture can be sometimes will not be correct. So I still expect that there is a, and to say this is a Boeing, how will we confirm that this is a physiological Boeing or this is a pathological Boeing? Is there any way? Is there any intermallular distance or something that we can
The
calculate and
intermallular
measure?
distance, we calculate the intermallular distance, and
So okay, so that is one important thing I think we need to say because to rule out the physiological bowing in that way. And second thing, whenever you talk about the florid rickets clinical features, uh, usually we expect that the child is severe acute malnutrition, maybe on a lower side of the moderate acute malnutrition, and because these are the usually the late clinical features. In the initial phase, they are not the initial clinical features. When you are seeing this much of bowing and this much of muscle mass in this particular child, I think probably the port belly I'm not expecting in this particular child. So these are the clinical features whenever you speak, whenever you talk in exams that this is a nutritional rickets and we go towards that side, we need to be try to correlate all the things. Okay.
okay, so so the systemic examination was predominantly normal, sir. Higher mental function was intact. The child was conscious, oriented. There was no motor or sensory deficit. Cranial nerves were normal. Um, in respiratory system, the child did not have any pneumonia. There was bilateral entry was present. There was no added sounds, and costochondral swelling was present, which was non-tender and rounded. So, the abdomen was soft and distended. However, there was no organomegaly, no scars or dilated veins visible, and cardiovascular examination was normal with no murmur. The summary post clinical examination is suggestive of a 16-month-old male child, first born of a non consanguineous marriage, presented with progressive bilateral bowing of lower limbs and delayed independent walking. The development was age appropriate until 1 year of age. Currently, there's isolated mild gross motor delay with a development quotient of 81, likely secondary to the mechanical limitation. The dietary
Okay. Any
assessment
any
revealed.
any other cause that may cause this gross developmental delay? Uh, is there anything that is right? One thing is the mechanical, and second thing, can vitamin D itself will be the reason for this developmental delay?
Yes, sir, it could be.
Okay. So what is the reason for that? Probably there's why there is a delay in gross motor secondary to vitamin D.
So one could be because of laxity of the ligaments. The child is not able to bear weight, and
So actually, the
there's
muscle
cons-
strength is also
yeah,
gone down with the
muscle
vitamin D. So
strength has
that's
gone down, and there's
mm,
proximal muscle weakness
mm.
with the deformity. So already that was mentioned.
So, so that may be one of the reason other than the mechanical defect.
Yes, sir.
Okay.
So the dietary assessment revealed a delayed complementary feeding with significant calorie deficit, absence of vitamin D supplementation, and limited sun exposure. On examination, the child appeared undernourished and had classical rachitic stigmata, which included frontal bossing, rachitic rosary, Harrison sulcus, widened wrist, and genovarum. The systemic examination was otherwise unremarkable. The overall clinical picture is strongly suggestive of nutritional rickets, secondary to vitamin D deficiency, along with iron deficiency anemia, and the background of a moderate acute malnutrition.
ठीक है.
At the end of our history diagnosis, we had a lot of differential diagnosis, which were pretty much everything was ruled out at the end of clinical examination. And it is a purely nutritional cause of vitamin D deficiency rickets.
Okay.
So this is the X-ray of the child showing metaphysis, showing fraying and cupping with widening of the distal end of the metaphysis, and I think you can appreciate the post tabulations of the diaphysis. The investigations of this child showed a severe anemia with a Menser's with a Menser index of 70 and a HB of 7.8 with a MCV of 62 and RDW of 19%, and peripheral smear showing microcytic hypochromic consistent with iron deficiency anemia. The total serum corrected calcium was 9 milligram per deciliter, which is normal, and the serum phosphorus was 3.5, which is low for age, with elevated alkaline phosphatase of 980, and vitamin D levels were 3 nanogram per meter, which is severely deficient.
Okay. Dr. Pavitra, can you go on the back slide? Okay. Here,
So,
on the investigation, the lab investigations.
sorry, sir.
Lab investigations.
This
Okay,
one.
so here you says the corrected your diagnosis till now is on the basis of history and general examination and systemic examination is primarily the nutritional rickets, it looks like. And your findings is also suggesting toward that side. And there is a florid rickets. And the calcium you said there isn't, the corrected calcium is 9. So well, what you expect in nutritional rickets in general?
So the calcium can be low or normal, so in nutritional rickets,
Okay.
and the phosphorus is predominantly low, very rarely normal, with elevated alkaline phosphatase and vitamin D
Okay.
levels below
So
12.
you usually expect calcium is low or normal, but most of the time the calcium is normal in the initial phase of the rickets. What you are talking at this point of time with the classical stigmata of the rickets and the clinical feature and the radiological picture, probably I still feel that at this point of time there should be calcium should be on a lower side. That maybe this value may be normal in the initial phase when the child initially presented with the bow legs. But when you are having so many clinical features suggestive of nutritional rickets, you usually expect that this calcium should be on a lower side. Okay.
This child was managed with oral vitamin D supplementation as per IAP. We had given 3000 IU per day and a calcium of 80 mg per kg per day. Complementary feeding counseling was reiterated to the mother and was advised to give at least 2 to 3
So,
large
Dr.
bowls of
Pavitra,
food.
this will be covered in his lecture. Dr. Mahesh, you can ask any other question relevant to the case to Dr. Pavitra, and then we can wind it up and start your lecture on diagnostic approach.
So I think in between I already thought whatever there may be question marks or there may be queries that examiner can ask. So till now this looks like to be a very good presentation, Dr. Pavitra.
Thank you so much,
So
sir.
I think the other people, if they are having any question, they can ask those questions.
So what is the shape of this rachitic rosary and how do you differentiate between its rachitic rosary of vitamin C deficiency or scurvy versus rickets vitamin D deficiency?
So the shape of the rosary, sir. So we actually examine the child from behind, with the elder child to raise their hands up, so the rosary is even more visible, and then we palpate from behind. So in rachitic rosary, it is rounded and it is non-tender. In scorbutic rosary, it is angulated and it is tender. And we have a third variance in mucolapitosis. Also, we have a rosary which is spindle shaped, sir. So that's how we differentiate the three.
Oh, thank you. So we have other PG students also. So you can ask any questions to Dr. Pavitra if you want. Otherwise, we can wind it up. So in chat, Dr. Vijay, are there any questions in chat? So there are no questions in chat. Thank you, Dr. Pavitra. You had a very nice presentation. So now we will be beginning the lecture by
Thank you, sir.
Professor Mahesh Maheshwari. So he will be discussing the diagnostic approach to rickets. Over to Dr.
Okay.
Mahesh.
Okay. So can I share my presentation now?
Yes, yes, you can share, please.
Okay. Is my presentation available? Is it visible?
Yes, yes,
Yes.
it's
I will
visible.
just go
You
back
are
to my
out.
slides.
So
Okay.
you have to discuss the diagnostic approach only. The management part would be discussed by Dr. Devi Lakshmi.
Okay. Just a minute. Is my presentation is visible? I'm not able to see my own presentation.
Now it's not visible. Previously it was visible. Yeah, now it's visible.
Okay. Okay. Uh, Very good evening to all. I think in the initial presentation, I was just driving, so maybe uh, so there is only one comment other than this, whatever we commented on Dr. Pavitra's presentation after a good presentation. I think in history taking also there is some history that is related with the bone pain. Probably there are few specific history that it is very difficult to elucidate in a young child. So thank you, Dr. Jaivinder, Dr. Anurag, Dr. Ravindra, and the team PEP for giving me this opportunity to interact with these young minds on rickets and children. As discussed, I will try to stick with this, but because this program is primarily for the postgraduates, so I thought what are the usually the questions that comes in the exam and what a postgraduate should know in terms of both theory exams and the practical exams. So most of the time there is a question comes in paper one that what is the physiology and factors that is affecting vitamin D biosynthesis and its impact on the bone health. So we are going to cover that in short. And there's a definition, pathogenesis, basic pathology, and biochemical defects in rickets. And then clinical features and evaluation of a child with the nutritional and the non-nutritional rickets, and how to differentiate between a calciopenic and phosphopenic rickets. And then management, obviously, Dr. Divalakshmi is going to talk in later stages. So, whenever we talk about the vitamin D, all of us know that it plays a very essential role in skeletal health by regulating the normal blood levels of calcium and phosphorus. It is also implicated in the various pathogenesis of various diseases like diabetes mellitus, malignancy, immune disorder. There are many more that where the nowadays that vitamin D is implicated. All of us well aware that there are two main forms of vitamin D: vitamin D2 ergocalciferol and vitamin D3 that is the cholecalciferol. Vitamin D2 is primarily derived from the plant sources, and vitamin D3 primarily comes from the animal sources. So, 90 to 95% of the vitamin D is actually synthesized in the skin. Remaining 5% comes from the diet. So, whenever you exposed to the sunlight, the 7-dehydrocholesterol is converted into the vitamin B3 in a particular ultraviolet rays, and then this will be remaining will come from the diet, and that will go to the liver where there is a 25 hydroxylation occurs, and this will go into the kidney and there will be an alpha hydroxylation occurs, and ultimately there is an active form of vitamin D, that is vitamin 25 dihydroxy vitamin D is there. What are the different functions of vitamin D? So this active vitamin D work on all three: intestine, bone, and kidney. In intestine, this increases the calcium and phosphate absorption. Bone, it usually help in the absorption of calcium and phosphorus. In kidney, it facilitates the action of PTH on distal tubule and cause the calcium absorption. So it is primarily a calciumic hormone where it is helping increasing the calcium in the serum. Then there are various factors that affect the vitamin D synthesis. So these are the few things that you need to be very clear when you are asking in the history taking that what is the in your general examination in history. So white color people usually require only 10 to 12 minutes of exposure to the sunlight. In Indian color skin, you usually require 30 to 120 minutes of exposure to the sunlight in a particular daylight between 10 a.m. to 4 p.m., 290 to 315 UVB. And then this is converted and there is an inactivate form, so there will not be toxicity is not there. Then this vitamin D synthesis is lesser at the high altitude. So just like the first patient that probably belong from a higher altitude, and there are various products that can affect the sunscreen. There is clothing pattern that will affect the vitamin D synthesis, and obviously the seasonal variation is also there. There is a decreased vitamin D synthesis in winter. So this is the thing that you need to talk about whenever there is a first question that is asked in the exam. When we talk about the rickets, how can we define rickets? Rickets is a disease of the growing bone uh, due to the failure of mineralization of the growth plate and osteoid matrix. A heterogeneous group of acquired, or you can other way you can say it's a heterogeneous group of acquired and inherited diseases that result in disturbances of calcium and phosphate homeostasis and thereby affect the growth bones. So there are key modulators of bone homeostasis. We know that there are three things: PTH, parathormone, FGF23, and vitamin D, active form of vitamin. This integrate among themselves and result in maintaining the calcium in the serum, so that it maintain the homeostasis. And this calcium is primarily regulated by the intestine, and phosphate is regulated at the level of kidney. This is very important to understand when we are talking about the phosphopenic rickets or calcemic rickets. So this is important thing that you need to remember. What is the pathogenesis or pathology of vitamin D of rickets? So we can classify this particular rickets in calcipenic rickets or a phosphopenic rickets. Calcipenic rickets is primarily the PTH dependent rickets, and phosphopenic rickets is FGF23 dependent rickets. But important thing in both, there is a renal phosphate wasting. In calcipenic rickets, this parathormone results in renal phosphate wasting. In FGF23, there is a tubular defect and there is a tubular reabsorption problem, and that will result in renal phosphate wasting. So ultimately, in rickets, either this is a calcipenic or phosphopenic, the most important finding is the low serum phosphate. So that is the fundamental for development of rickets. So whenever we see a child with rickets and whenever we evaluate the investigation, this we need to keep it in mind. And this hypophosphatemia result in impaired apoptosis of the hypertrophic chondrocyte in growth plate. And because if you see in this particular slide, these are the chondrocytes, they are running in the columnar fashion. And when this majority occurs, they become hypertrophied, and after that hypertrophy, there is a apoptosis, and there is the blood vessel invade, and ultimately they will result in a mature bone. What happen in vitamin D in rickets? This apoptosis will not happen, and this will result in a not a clear-cut columnar arrangement, and that will result in all the clinical radiological features what we usually see, splaying, fraying, and cupping of the metaphysis. This what we can see because of this particular reason. And so this is the pathophysiology of rickets in any related with this. What will happen in nutritional rickets? There is a low 25 hydroxy vitamin D. This low vitamin result in low 125 hydroxy vitamin D. This may be due to various reasons, what we talked about in the beginning. And there is a drop in the serum calcium below the individual set point. Or if you are taking a low calcium from the diet, that can also be reason for this thing, and that result in secondary hyperparathyroidism. So in calcipenic rickets, when we are talking about the nutritional ricket, there's the secondary hyperparathyroidism result in decreased calcium and increased phosphate excretion, and that will result in this parathormone also causes the prolonged phosphaturia, and this will result in low serum phosphate. So what clinical feature we usually see? Apparently, that is the wrist widening. We will see the rachitic rosary or growth plate widening. That is primarily because of the hypophosphatemic effect, not because of the hypocalcemic complication. Hypocalcemic complication usually present as a, just like an hypocalcemia, you can have seizures, you can have the tetany, you can have older children, there may be a possibility. Sometimes in a severe hypocalcemia, they may present with the dilated cardiomyopathy. So what are the different causes of calcipenic rickets and phosphopenic rickets? If we talk about the calcipenic rickets, there is a vitamin D deficiency. The reasons we already discussed: inadequate sun exposure, inadequate intake, or malabsorption, defective vitamin D metabolism that can result in VDDR1 or VDDR2, and chronic renal failure, hepatobiliary insufficiency, anticonvulsant. There are a few anticonvulsants that can cause this calcipenic rickets, calcium deficiency itself, and there may be a renal tubular acidosis that can also be there. Then phosphopenic rickets, just simply because of the phosphorus deficiency, especially you can see in the premature infant or a person who is taking a prolonged antacid, or there may be a malabsorption syndrome where you get a phosphopenic rickets. Otherwise, this is primarily a renal losses of the phosphate. That was the reason for the phosphopenic rickets. We will talk a little bit about this part also in the later slides. When we see calcipenic rickets and phosphopenic rickets, just like Dr. Pavitra said in the beginning, the calcipenic rickets usually an early presentation, and phosphopenic rickets is the late presentation. Bony pain is a calcipenic rickets is very common. So Dr. Devinder already talked about, so sometimes these children with severe malnutrition can present with the pain, irritability whenever you are picking up the child, and there may be an associated other multivitamin deficiencies. Common deformity, xenovelgum is the more common deformity in the calcipenic rickets. The calcium deficiency signs that can be there, and these clinical features, actually the age-dependent clinical features. In calcipenic rickets, you will get the dental hypoplasia, but in phosphopenic rickets, this is absent. Biochemical parameters, if you will see in calcipenic rickets, the calcium may be normal or decrease. Phosphate is always on a lower side in both the conditions. ALP is more significantly rise than the phosphopenic rickets. PTH dependent rickets because calcipenic, so PTH is on a higher side. In phosphopenic rickets, this PTH usually you get the normal. ALP may be written on a higher side, but not very high. And osteopenia can also be present in the calcipenic rickets. So this is against what I told at that point of time about nutritional rickets. Whenever you will see a calcium deficiency, so if you see this particular slide, in this we will say ideally there should be the clinical manifestation usually develop when there is a both calcium and vitamin D are deficient or insufficient. They usually didn't come when one of them is normal. So there may be a biochemical abnormality that can be there. If vitamin D is insufficient and calcium is also insufficient, then there'll be a probably biochemical changes that you can see, but not the clinical features you will see in most of the scenarios. In rickets, usually you will get a deficient vitamin D, or maybe calcium deficiency is also insufficient or deficient. So both of them should be insufficient or deficient. That is very important. So this is the reason why I thought probably the calcium should be lower side in that particular at that point of time. Then there are various clinical features. They are age-dependent clinical features. Even the early rickets, they present in the early infancy. You may get a craniotabes that can be there, poor feeding, irritability, hypocalcemic seizures, apnea and stridors. These can be the initial clinical features. One important thing probably that was missed in the presentation is the talking about the fontanelle in the clinical examination. So there is no, I think that was not there, that what was the status of the fontanelle and the sutures. In older different children, they may present with a gross developmental delay because of the muscle laxity, and at the same time, there may be if there is a mechanical defect. But the other developmental milestones are usually normal. Seizures can be a clinical manifestation. Very rarely, if this is because of the hypocalcemia, severe hypocalcemia, they present with the heart failures. Clinical examination, you may get hypotonia. Swollen joints you can get, but you need to classically differentiate with the vitamins C deficiency, scurvy also, because that they usually present with the swollen knee joint. The rachitic rosary and features of heart failure I already talked about. So in older children, they come with the swelling of the wrist or knee or ankle result. So that is their first common presentation, primarily the Boehringer forms. And then there may be a possibility of the fractures, delayed development, abnormal dentition. So these are the common presentation in the older children. Evaluation, very well described by Dr. Pavitra. And so there is the diet history the most important. I think there should be more elaborate diet history that you need to take at that point of time. Then the sun exposure is also equally important. And then the antenatal, natal and postnatal history. If an older child is coming, then the medication that is important. If you are started thinking about a non-nutritional rickets, then there is a possibility you start thinking about the other system involvement, that may renal involvement, liver involvement. Family history is very important. The initial phase to say if we are dealing with primarily with the phosphopenic rickets or a calcipenic rickets in terms of in the initial presentation. So initial history taking, that family history is very important. And then definitely the presenting features to rule out the other things. Anthropometry should be taken in a proper way. Severe acute malnutrition usually present with the fluoride rickets and other multivitamin deficiencies. Moderate acute malnutrition can present with some degree of vitamin D deficiency and some clinical features of rickets. But usually we don't see in a moderate acute malnutrition or in child all the clinical features suggestive of in a nutritional rickets. So pallor and blood pressure and the other clinical features suggestive of the non-nutritional rickets. So if you're thinking a non-nutritional ricket, then you can think about the liver disease related clinical manifestations, icterus, pruritus, ascites. VDDR2, if you are suspecting, then alopecia, epidermal cyst, dental abscesses and pulp space infection is more common in the hypophosphatic infections. Gait abnormality is very common in the X-linked hypophosphatemic rickets. And then other features of other vitamin D deficiency and the calcium deficiency clinical features. When we go to the investigation point of view in nutritional rickets, because it is primarily a clinical and historical diagnosis. So you usually don't require a battery of investigation. So in the initial phase, you will require a serum calcium, serum phosphorus, and alkaline phosphate. These are the three primary investigations that usually give a hint toward that side. So in early phase, you may get a normal or decreased serum calcium. or in a moderate phase, or in a again the serum calcium may be normal or decrease, but in severe rickets or severe vitamin D deficiency, usually calcium is on a lower side. Serum phosphorus, you may get the serum phosphorus is on a on a lower side. Alkaline phosphatase you will get in severe on a very high side. Then the investigation, special investigation that comes, the PTH. If you want to decide this is a calcipenic rickets or this is a phosphopenic rickets, then the role of PTH will come. So if there is a PTH is on a higher side in a calcipenic rickets, vitamin D is usually not required in the routine assessment of or when you are strongly suspecting the nutritional ricket. But if you are suspecting non-nutritional rickets or there may be some confusion, then in that scenario you may require the 25 OSD, and in some scenarios you require the 125 OSD. Not in all cases you will require the 125 OSD. So I already talked about all this important thing. Only thing that whenever you're taking a phosphate sample, you should take it in a fasting sample, because otherwise it may come on a normal side and there may be a confusion related to the diagnosis. And so that is an important thing that you need to see. And the second important thing, if someone already started the treatment for the nutrition rickets, in the initial phase, you may get the initial alkaline phosphatase on a higher side. So there may be possibility that initially the ALP will increase. So that is one important thing that you need to remember. Radiograph, very characteristically described in the case presentation. You will get a characteristic fraying, cupping, and splaying. And because of the initial phase, there may be a loss of demarcation between the metaphysis and the growth plate, and loss of provisional zone of calcification. So that is an important thing. And later characteristic changes comes with the fraying, cupping, and I'm sorry, there's some call. Am I visible? My slides are visible?
No, no, your slides are not visible. Your WhatsApp was visible.
Okay.
Yeah, now they are visible. The slides are visible, Dr. Mahesh, no?
Hello, am I audible?
You are audible. Your
Yeah,
slides are
okay, sure. Thank you.
just wrap
So
in next 5 minutes, Dr. Mahesh.
yeah, I will just cover it. And infants and young children, so this is very important, which X-ray you wanted to take in this particular children, and when to suspect non-nutritional rickets, because this is the approach. So if the child's presentation is less than 6 months or more than 2 years, jaundice or recurrent vomiting, chronic diarrhea, this is just suggestive of hepatic or GI causes, clinical features that is suggestive of renal cause associated with rickets, Wilson disease, if there's an associated with cataract, positive family history, you will may get in RT and hereditary forms of rickets. Alopecia is a very characteristic clinical feature of VDDR. Predominant lower limb involvement with frequent dental abscess and family history is again a very classical clinical feature of familial hypophosphatemic rickets. So there are few clues. So these are the clues we already talked about. So if secondary systemic disease, VDR type 1, onset is usually early, tetany, seizures, delayed dentition. And type 2, you will again get the same features, but alopecia and ectodermal defect is more common. Refractory phosphopenic rickets can present with polyuria, polydipsia, and other clinical features. In hypophosphatemic clinical features, usually the later onset, lower limb is more involved than the upper limb. Genu varum is more common. This is what we already discussed. What investigation then you need? Here you need many of the investigation other than the first line investigation. So you need to the relevant investigation like creatinine, blood gas, urine calcium, or creatinine. And so I will not go in detail in view of time of shortage is there. So vitamin D dependent rickets type 1 and type 2. There are further vitamin VDDR type 3 that can be there. So that is more of an X-linked hypophosphatemic rickets is the phosphopenic ricket that is there. So that is one of the commonest rickets that because of the FX mutation. And there is an FGF23 expression. So there is a tubular absorption is the problem. And that will result in the clinical features suggestive of rickets. And that you will get normal calcium, decreased phosphate, normal PTH, increased ALP, And the most important investigation is the low TMP-GFR. So that is very important to see. And then vitamin D is usually normal. So just to summarize the approach, whenever you suspect the rickets, so there is a clinical signs. If the clinical signs, you need to confirm. If there is an increased alkaline phosphatase, X-ray changes are there, then and you are thinking there is a nutritional rickets is already out. So in that scenario, you can measure the serum bicarb and creatinine, where the most other commonest cause of rickets, secondary non-nutritional rickets is the renal rickets. So the blood gas and electrolytes is a very important clinical scenario. Then phosphate is already there. Then you need to see the PTH. If PTH comes normal or low, then the measure the urinary level of urine level of phosphate. If the urinary level of phosphate is also low, then that suggests there is an insufficient phosphate intake, and you need to find out the malabsorption or extra renal loss from the body. If there is a urine level phosphate is on a higher side, measure the serum level of FGF23. If this is normal or low, it suggests there is an hereditary hypophosphatic rickets with hypercalciuria and Fanconi syndrome. If this is high, then you need to think about the hereditary hypophosphatic rickets, acquired forms of hypophosphatic rickets that can be there due to the high levels of FGF23. Calcipenic rickets, again, this is if the PTH is on a higher side, then you need to can measure the 25 OSD. If 25 OSD is low, then you think VDDR1B or VDDR3. If this is normal or high, then nutritional or vitamin D deficiency can be think of. If the vitamin D level is normal or high, then 125 you require the estimation of this, and depending on that, you can decide the various classification. So this is the in general approach that was there to go, how to approach a child in a phosphopenic rickets or calcipenic rickets or nutritional rickets or non-nutritional rickets. So I think I tried to finish it in a little fast because of the time constraints. So
Yeah, Dr. Mahesh, thank
over
you.
to you, Dr. Devinder.
So as we are already running late 5-6 minutes, so if there are any questions, you can put in the chat box and Dr. Mahesh will try to answer it. And now I hand over to Dr. Vijay Jaiswal. So he will be carrying to the second case.
Thank you, Dr. Jay. First we have discussed the nutritional type of rickets and followed by presentation of Dr. Mahesh, which was really very important and lucid. Now I invite this for second session. Dr. Sonal is going to present. She is MD third year residents at AIIMS Bhopal. And the guide is Dr. Mohammad Salik. He is DM resident pediatric endocrinology at AIIMS Bhopal. And I'm really happy to introduce Dr. Divya Lakshmi. She is Associate Professor and Consultant Pediatric Endocrinologist in Department of Sri Ramchandra Medical College, Chennai. So I invite Dr. Sonal to present her case, and we are going to discuss later. And Dr. Divya can, in between, she can ask questions or any panelist can ask questions. So over to you, Dr. Sonal.
Thank
Please
you,
go
Dr.
ahead.
Vijay, for the kind invite, and we can
No.
proceed with
It's my
the
pleasure.
case presentation.
Yeah.
Yes,
Thank you,
thank
Doctor.
you, sir.
Thank you.
Thank
Yes,
you,
please
sir.
go ahead, Dr. Sonal.
Yes, sir. I'll be presenting a case on progressive skeletal deformity under the guidance of Dr. Salik PK. So we had a 10-year-old boy, Master A, resident of Chinwada, Madhya Pradesh, the informant being parents and the child himself. He comes with the chief complaints of progressive deformity of limbs and not gaining height compared to his peers since 5 years of age. History of present illness. Child was apparently normal till 5 years of age. Then the parents noticed progressive deformity of limbs involving bilateral lower limbs initially, then followed by upper limbs and then the chest wall. This deformity was insidious in onset and gradually progressive over 5 years. It was bilateral and symmetrical in involvement. The parents first noted it in the lower limbs in the form of anterior and lateral bowing. Subsequently, they observed it in both the upper limbs in the form of outward bending of the forearm and chest wall deformity in the form of forward bulging. He also complains of pain in both legs after prolonged walking, which is activity related. There is no history of rest pain, no history of nocturnal pain, and there is no pain in the chest deformities noted.
Sonali,
The mother
1 minute.
Yes,
Yeah.
ma'am.
So, Yeah, I'm sure like all of us can, from the complaints itself, we come to know like what is the diagnosis is. Okay. My question for you is, if a child is more than 5 years old and the deformities are being noticed around that time, why the child is having chest deformity?
Ma'am, they have noticed it at 5 years, but we do not know when was the onset of this disease. They had the chief complaints that he had it in the lower limbs, and then they have observed it in the upper limbs and chest wall.
So probably the illness must have been going on, since infancy or, as a young child. So this is not something that has to do like from 5 years onwards. Okay, right? So
Yes,
chest
ma'am.
deformity indicates that, as an infant only, the child had some issues. Okay,
Yes, ma'am.
right? So just wanted to highlight on it. Yeah,
Yes, ma'am.
proceed.
The onset we do not know, but the mother has observed it at the age of 5 years. Since then. Yes, ma'am. The mother has also observed an abnormal gait due to the deformity. He is able to walk independently to the school, but is not able to run, which he was able to perform previously. The child does his daily routine activities and school activities. There is no history of difficulty in walking short distances. The mother says that her child appears shorter than his classmates and is the shortest in his class, and the weight gain is relatively better than height gain. Coming to negative history, there is no history of recurrent fractures after trivial traumas. There is no history of frequent falls, no history of difficulty in climbing stairs or rising from a sitting position. There is no history of joint pain, swelling, redness, or morning stiffness. There is no history of any limb length discrepancy noted since birth. There is no history suggestive of polyuria or polydipsia. There is no history of any dehydration episode, no history of recurrent UTIs, oliguria, or swelling of the body. There is no history of chronic diarrhea. There is no history of greasy stools, night blindness, bleeding tendency, no history of poor appetite. There is no history of any abnormal movements or seizures. There is no history of visual difficulty or hearing difficulty. There is no history of delayed dentition, caries tooth, or recurrent dental abscesses. There is no history of any prolonged drug intake. There is no history of patchy or total hair loss.
Sonal, one more thing. You have mentioned like there is no joint pain, swelling, redness, and all these things. Was the child having pain while walking or like, any with the movements? Was the child having any pain?
Yes, ma'am. He complains of activity-related pain. After walking for a long distance, activity-related pain was his complaint. So I have asked the joint pain, swelling, redness, and the morning stiffness to rule out whether it is any inflammatory pathology which is causing it.
Okay. Can you
Just to rule out.
enumerate 2 or 3 causes on like, pain that happens in rickets? Cause
Yes,
of
ma'am.
pain that happens in rickets. Causes of pain.
Yes, ma'am. Causes of pain, usually the bone pain is due to the defective mineralization. There is, because of the defective mineralization, there can be mechanical stress and stress fractures. And second is due to proximal myopathy. This is usually because of the low calcium and the low mineralization and the proximal myopathy, ma'am.
Is it myopathy? Myopathy causes weakness, muscle weakness. What else it is? Myopathy happens in a different form of rickets. Muscle pain happens in a different form of rickets, isn't it?
Yes, ma'am.
Yeah. Excitation, contraction, coupling.
Yes, ma'am. Due to the low calcium levels, it is usually
Yes.
bone pain is seen in the calcipenic form of rickets.
Myalgia also seen in calcipenic form of rickets.
Yes.
Okay. Myopathy and the muscle weakness happens in
Ma'am, that can form in even the renal tubular acidosis, RTA form.
yes, resistant rickets or refractory rickets. Okay, right? Especially when you lose phosphorus. Okay. Why for loss of phosphorus or hypophosphatemia causes myopathy or muscle weakness?
Ma'am, phosphate is needed for the muscle, like ATP is needed for the muscle
Yes.
contraction. So there is low phosphate, so the ATP is not there for muscle
ATP is not
contraction.
being produced.
Huh.
So yes, so anything that relates to the muscle excitation doesn't happen. So that causes myopathy and muscle weakness. Okay, right?
Okay, ma'am.
So relatively speaking, calciphynic rickets are the most painful rickets. Okay, right? That doesn't mean that phosphopenic rickets doesn't have pain. Yeah, especially if they go untreated, for a long time. They can also lead to whatever you said, stress fractures. Poor bone mineralization. Okay, right? So all these things can cause pain in phosphopenic rickets as well. Okay, right?
Yes, ma'am.
Very good. Yeah. Good. Proceed, please.
Yes, ma'am. Coming to the treatment history, the child was initially managed at a peripheral center. We do not have any documents of any biochemical evaluation performed earlier, and he was on and off treatment for the last 3 years with some empirical treatment. We do not have the details of it. We are just suspecting he might be prescribed some calcium and vitamin D supplements. Later, he has visited an orthopedician where he was advised orthopedic braces for his skeletal deformity, but the child was not compliant to it due to his pain. Later, we found when he presented to us, he had some OPD papers, and we confirmed that he has completed a 3-month course of calcium and vitamin D in our own hospital in the orthopedics department in appropriate doses. However, even after the completion of that, there is no improvement in his deformities. The child is a second born to a non-consanguineously married couple. There is history of similar lower limb deformity and short stature in mother. The mother is not evaluated or has received any treatment till now. There is no history of fractures. Coming to the birth history, the
Have
child
you
is
seen
born.
the other sibling? The other sibling
Yes,
doesn't
ma'am.
have any bone.
The elder sibling looks normal, ma'am. He does not have any complaints.
How old is he, by the way?
He is, ma'am, 13 years old.
Oh. Yes.
Birth history, the child was born out of LSCS, full term with a birth weight of 3.5 kg. There is no history of any NICU stay. There is no history of congenital skeletal anomalies noted. The child is immunized as per the national immunization schedule till 5 years of age, and he belongs to a lower socioeconomic status. Development history, the child has achieved age appropriate milestones. However, now he is not able to climb stairs. He is able to climb it with difficulty. He is unable to jump and run, which he was able to perform previously. Dietary history.
So, what is your opinion on the developmental history in this child?
Ma'am, opinion is that he has achieved the age appropriate milestones initially according to the history, and he goes to the school and he is average in his studies. And for the last whenever his complaint started, the mother says that he is going walking to his school, but there is difficulty in climbing stairs. He takes help. There is unable to jump. So because of the skeletal deformity, the gross motor, there is some regression, but which is explainable because of his skeletal deformity.
Okay, so with this history in mind, can you place the child in, whichever form of rickets is?
Ma'am, there is a later onset of his deformity, ma'am. Like if it was involving in the initial form, like involving the initial development, then we used to think more of a calcipenic form. It has involved started at a later age, and the initial development is age appropriate, so it goes more towards the phosphopenic, ma'am, here. Or we can consider the other causes of skeletal deformity as well, ma'am, like which does not involve the CNS or the developmental part of the child.
So it is
Like some
actually probably because of the pain that is associated with the calcipenic rickets. Child generally restricts its movements. Okay, so that's why you get an motor delay in calcipenic rickets rather than a phosphopenic rickets. Okay, right?
Yes, ma'am.
Once the myopathy sets in or the muscle weakness sets in, maybe phosphopenic rickets will have its developmental delay component added, but that comes at a later phase. Okay, right?
Yes,
Yeah.
ma'am.
So this again is a pointer towards you are dealing something with the resistant rickets. Okay.
Yes, ma'am.
Yeah.
Coming to the dietary history, the child was exclusively breastfed till 5 months of age, and the complementary feeds were started thereafter. The child has a predominantly vegetarian diet and he eats from the family pot. There is history of low intake of milk and dairy products, and there is history of inadequate sun exposure. On further probing, the child has not received any vitamin D supplements during his infancy. Based on the 24-hour diet recall method, he is having a 30% calorie deficit and a 20% protein deficit. Coming to the summary, a 10-year-old male born out of non-consanguineous marriage, belonging to lower socioeconomic status, developmentally appropriate for age, with 30% calorie and 20% protein deficit, presented with progressive skeletal deformity, lower limbs predominantly more than the upper limbs and chest, and poor height gain noted since 5 years of age, which is non-responsive to vitamin D and calcium therapy, with a similar lower limb deformity and short stature in mother.
What is your provisional diagnosis?
Yes, ma'am. I have made a table for that, ma'am. As the child is having progressive skeletal deformities predominantly in the lower limbs, there is poor height gain, there is a similar deformity in the mother, and the child has received treatment, appropriate treatment for 3 months, but there is no response. So this is suggestive of a refractory rickets. So in
How
that,
long you can wait after giving? Suppose you are seeing this child for the first time, and you notice vitamin D deficiency. You are treated treated with vitamin D and calcium. How long you can wait before you label the child as resistant rickets
ma'am, 12
or
weeks
a
of
refractory
therapy.
rickets, whatever?
12 weeks of therapy, ma'am.
Okay, right. We will see. Okay, I'm going to show you a slide on when it is. Okay, so generally, radiological healing when it starts. What is the first pointer towards healing? Biochemical, radiological, or clinical? Which one comes first?
Ma'am,
Which one
biologically
gets
first.
corrected? Which one gets corrected first in? Of course, this is not resistant ricket. This is a vitamin D deficiency ricket means. Which one gets corrected first?
Ma'am, first, biochemically, the phosphate and calcium starts to normalize by 6 to 10 days. And
Phosphorus followed by alkaline phosphatase.
ALP takes time,
Okay.
ma'am. ALP takes almost like 3 months to reach the normal levels. And PTH also takes around 1 month to reach the normal levels. In the radiographic findings, at 3 to 4 weeks, we will first find the healing line, ma'am, of rickets. And by 12 weeks, we can see whether the rickets is healed.
Yeah. So, 4 to 6 weeks of time, if there is no radiological evidence of healing of rickets, I mean, it is very unlikely to be a vitamin D deficiency ricket unless there is a compliance issue. Okay, right? So if the patient is taking the medications properly, by 4 to 6 weeks of the time, you will expect what is that called as zone of provisional calcification to happen. Okay, if you don't see that, if the compliance is all right, then it is likely to be a resistant rickets or a refractory rickets. Okay, right? Yes. Proceed,
Yeah, for completion's sake, we had considered the other DDs also. I would like to explain why I had considered and what are the points favoring and against, ma'am. So, vitamin D dependent rickets, there is progressive skeletal deformities, there can be a family history, and in this also there can be no response to conventional treatment. But the features against it is it has presented after infancy, and there is no feature suggestive of hypocalcemia, ma'am. There is no history of any abnormal movements, tetany, seizures, and if we are considering more like VDDR type 2A, then there is no even history of hair loss. For renal tubular acidosis, I have asked, there is no history of polyuria, polydipsia, dehydration episodes, or muscle weakness. And for skeletal dysplasia, the child was apparently normal at birth, and that is less likely. And for osteogenesis imperfecta, there is no history of recurrent fractures after trivial trauma. And for CKD, there can be skeletal deformities with growth failure. However, on history, we have not got any features suggestive of renal disease. I would like to further see the examination part also for some features like anemia, etc. For malabsorption syndromes, there is no history of chronic diarrhea or fatty malabsorption like the greasy stools, and the other fat soluble vitamin deficiency, like there is no night blindness, no bleeding tendencies. So that is also less likely. And for nutritional rickets, I have kept it at the end because the ricketic skeletal deformities is a supporting feature, but there are many features against it. That is the child has a poor response to prior treatment, and he has presented later in his childhood. So going to general physical examination, the child is conscious and oriented. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. There is frontal bossing noted. In the eyes, there were no signs of vitamin A deficiency. The hair and eyebrows were apparently normal. The child had a depressed nasal bridge, and on oral cavity examination, there were multiple dental caries. However, no abscess was noted. There was prominent ribs with rachitic rosary and Harrison sulcus seen. There was wrist widening bilaterally. There was bilateral coxa vera and genu valgum, that is knock knees, and the intermalleolar distance was 11 centimeter. So in this photographs also, we are able to see there is anterior and lateral bowing of both femur with anterior bowing of tibia. There is no apparent limb length discrepancy. There is no scoliosis or kyphosis, no vertebral tendencies. And in the vitals, the child was vitally stable, and even the BP was in the normotensive range, ma'am. So going to the anthropometry, the child had a weight of 20 kg, which is minus 2.19 standard deviation, a height of 105 centimeter, which is minus
Sonal,
4.87.
apart from dental caries, gingiva was normal. Huh? Dentition was appropriate to the age.
Yes, ma'am, it was appropriate. We have asked it also, like when did the milk tooth come? So there was no history of delayed dentition, and we saw the gums, and if there is any abscess, any other deformities, it was not there. Only he had dental caries, ma'am.
Okay.
The BMI was 18.5 kg per meter square. The MPH was 156 centimeter, and the child is below the MPH target. Seeing the upper segment to lower segment ratio, it is 1.1. The child is having a disproportionate short stature. The bone age was delayed, that is 6 years, and the SMR was prepubertal. Going to the systemic examination, no significant abnormality was noted. The RS, CNS, there was no focal neurological deficit, as well as in the per abdomen, there was no palpable organomegaly. And the CVS examination was also normal, ma'am. So the database we have is a 10-year-old boy presented to us with progressive skeletal deformities with poor height gain with onset in early childhood. And these deformities were predominantly affecting the bilateral lower limbs and had poor response to empiric therapy with preserved motor and cognitive development. There is no history of fractures. There is no history of abnormal movements. And there is a similar deformity in mother. On examination, the child is having severe short stature with disproportion. There is classical rachitic skeletal deformities, and there is dental caries. So in this DDs, which I had considered previously, so few of them I would like to rule out. Like for CKD, I also saw for features of anemia or hypertension that was not there. For OI, we had there was no history of fracture, and also the sclera was normal. So that is a slightly against feature. And skeletal dysplasia also, there was no other bony deformity noted at birth. For malabsorption syndromes, there was no features of vitamin A deficiency in the eyes and no like petechiae or any bleeding form. So malabsorption syndrome also is less likely. So based on the history as well as my examination, so I would like to consider it is a non-nutritional rickets and most probably hypophosphatemic rickets. So investigations, first in September 2025, when the child was evaluated in orthopedics department, the child had a low serum phosphate with a serum calcium of 8.72, a high ALP of 477 with elevated PTH 125, and the 25 hydroxy vitamin D was 9.09. The child was started
What
on
is the
calcium.
normal range, normal phosphorus in children? What is the normal phosphorus range in children?
Ma'am, here it can be like he's a 10-year-old, so we can consider like 3.5 to 5.5, ma'am. This is like significantly low.
Okay. So, see, younger the age, the phosphorus level can be even higher. Even a phosphorus
It
level
can be
of
in a very young.
7, not very young, less than maybe about 7, 8 years. Children less than 7, 8 years of age can have a phosphorus value as high as 7. Okay, right? So that doesn't mean that it is hyperphosphatemia. Okay, right? So children generally more than 10 years of age, their levels are actually comparable to adults, 3.5 to 5.5 or something like that. So younger the child, even a value of 3.5, okay, should raise an alarm that the child is having hypophosphatemia.
Yes, ma'am.
Okay, right? Just
Yes,
want to
ma'am.
highlight on the fact that, one should not wait. No, phosphorus is not less than 2.5. So it is not hypophosphatemia. So younger children tend to have more higher phosphorus level. So even a value of 3.5, 3.4 or something, it means that the child has hypophosphatemia. Okay,
Yes, ma'am.
right? Yeah.
Yes, ma'am. And at that time, they had even done the RFD. That was also normal, ma'am. That was done to rule out if there is any evidence of CKD. He had iron deficiency, that is 40.7. And he was started on calcium vitamin D supplements then. When the child presented to us in January 2026, we did a fasting sample. The serum phosphate was 1.81 mg per deciliter. The ALP was elevated. The PTH had slightly normalized to 58.5, and the 25-hydroxy vitamin D levels had also normalized. That is, from 9, it had become 35.3. So this made us think that it can be refractory rickets. And then
What
we
else is
evaluated.
abnormal in the initial table? I mean, sorry, yeah, there are like a couple of tables on the right side as well, but I'm going to talk on the table that is on the left side. What else has become abnormal compared from September to January?
Calcium has come in the normal range, ma'am. There is
Okay.
a hypophosphatemia. The ALP is still elevated. PTH has become normal, ma'am, normalized, and 25-hydroxy vitamin D has significantly improved, ma'am. And then RFT is also normal. Then, ma'am, the down part, are you asking, ma'am?
RFT only, creatinine only, I'm asking. Is that the January value creatinine is normal for a 10-year-old?
It is not elevated, ma'am. It is like 0.28 is.
0.28 is what? Low, normal, high?
It is low normal.
It is low. Okay. Which indicates what? So we are talking about rickets. Okay.
Ma'am, muscle
right?
mass
So,
also contributes to like
yes.
creatinine levels.
So there is myopathy and there is muscle weakness and then there is a muscle wasting as well. Okay, right? So, so that is why most of the hypophosphatemic rickets, when we evaluate, the values are always compared with the GFR or the creatinine clearance. Okay, right? So that is one thing. Okay. Yes.
Yeah, sorry to interrupt, Dr. Divya.
Yeah, we are running out of
Sonal,
time.
you are running late.
Yes,
So I
Yes, sir, I
request
will.
you to finish in
Yes,
time.
sir.
And Dr.
Yes, sir.
Divya is going to share her presentation because then you will be wiser, I think.
Most
Sir, I
of
will
my
finish it in.
presentation I have
Yeah,
asked.
that's fine. That's fine.
Yeah.
Okay.
Okay.
Sir,
Okay.
I
Thank
will
you.
try to wind up in another
Yes.
2 minutes, ma'am.
Yes, that is fine.
Yes,
Thank you.
sir. The urine calcium creat ratio was less than 0.2, which was suggestive of there is no hypercalciuria. The USG KUB was suggestive of no nephrocalcinosis. We did a VBG to rule out any evidence of metabolic acidosis, which was not there. So RTA was less likely. And for evaluating if there is any renal phosphate wasting, we calculated TRP, which came out to be 0.884. And for the TMP GFR, we plotted it on the Bijovitz nomogram. And the value was 2.04 mg per dl. This is low for the age. So the normal values I have written as 2.5 to 3.4. So this signifies there is renal phosphate wasting, even though the PTH is normal. So these are the X-ray. There is, we can see here, there is bowing of the femur. There is osteopenia, cortical thickening. There is metaphyseal abnormalities as seen in Rickets also. And we evaluated the mother's status. She had knock knees, and she had a similar profile. The TMP GFR was low and the serum phosphate was low. So on the genetic analysis, we got a FEX gene mutation, with the zygosity being hemizygous and the inheritance being X-linked dominant, hypophosphatemic rickets. And the classification according to ACMG was likely pathogenic. So I would like to keep my final diagnosis as X-linked dominant hypophosphatemic rickets with bilateral genu valgum with disproportionate short stature with iron deficiency. Thank you, sir.
Thank you, Sonal. That was a wonderful case to discuss. Of course, I would like to ask you a final question. Why TRP has come as normal in your patient? The TMP bar GFR, which is more more an accurate measurement of phosphorus wasting, that has come as low. But why TRP has come as normal?
The body is trying to reabsorb the phosphate, ma'am. So this depends, this does not consider the serum phosphate values as well as the GFR. So when this is not an accurate measure to see whether it is really a renal phosphate wasting is there or no. So for that, we will calculate TMP GFR, ma'am. This will also consider the serum phosphate levels.
So irrespective, see your initial phosphorus level was very low, no? 1.8 or something when you did the TRP. Okay, so that was very low. And when the phosphorus is very low, irrespective of the genetic defect or whatever, the mechanism, promotes the phosphorus reabsorption. So TRP becomes like almost kind of invalid when you have an extremely low phosphorus level. Okay, right? So that's why you must have got this thing. And again, as I said, actually, it has to be compared with the GFR. Most of the phosphorus equations that we do. Okay, right? So TMP bar GFR, tubular maximum for phosphorus with compared to the GFR is on the lower side. That indicates that it is a hypophosphatemic rickets. Okay. So thank you very much for your presentation. Wonderful case presentation from the entire team of AIMS. So thank you, everyone. I think, can I share my slide?
Yes, ma'am, you can share your slides and start your lecture.
Okay. Yeah, so this I have already, anyways, most of the points I have already discussed. So whatever has not been discussed, I will just highlight in my slides.
Dr. Vijay, can I make a comment?
Yes, sir. Yes, sir. Yes.
Yes, sir.
Hi, I'm Dr. Ravinder. It's a very nice case, very interesting case. One surprising fact for me, I mean, this is a 10-year-old boy. For last 5 years, it was not investigated anywhere. I mean, this is very surprising, weird. Dr. Sonal, what is the possibility? Because the patient is having this problem for last 5 years. And this is because X-linked disease. So obviously they noticed for last 5 years, must be there even before that. And as you said, even it was case was seen by in your hospital. So they must have do X-rays and etc. apart from these blood investigation and nothing before that. Dr.
Yes, sir.
Sonal?
Yes, sir. This is Dr. Salik. Sir, actually, the patient has been referred from orthopedic side after seeing the X-rays. There are lots of fractures there, lucid zone.
Yeah.
So they kept a possibility of phosphorus imperfect.
Okay. And before
Hello, am I audible?
No. Yeah, you are audible. And before that, in last 5 years, none has.
Actually, before that, the child has been not evaluated properly, sir. Unfortunately, even the mother had similar phenotype. When the child was admitted, we insisted the mother also has to go for a skeletal survey, but we hardly convinced her for getting a blood sample, which we sent by ourselves. The rest of the investigation still pending. Even we contacted the adult endocrinology team to have a look, but the mother was not ready to get evaluated further.
That is very sad part of the story because even MPH was less than third centile. Anyway, congratulations to you all, the team who have done a fabulous work.
Sir.
Thank you. And I mean that That's that's revealed a very sad part of in our country, that someone is having that situation and problem for last 5 years, and I mean it is undiagnosed. That's very sad. Anyway, congratulations to you all team.
Yes, sir.
Thank you, dear. Thank you.
Thank you, sir. So I
Thank
think we will, I'll go ahead with my slides. That's all right with anybody. If there are no more questions, can I proceed?
Yes, ma'am. Please try to concentrate on the management, the approach.
Yes, yeah. So this slide has already been discussed. So classification of rickets we do as calcipenic, phosphopenic, and inhibition of mineralization, where you have hypophosphatemia, hypophosphatasia, and then OI and those kind of disorders. And so how to differentiate calcipenic and phosphopenic rickets, this again has been discussed. So the painful rickets is more likely to be a calcipenic. The earlier the presentation with the developmental delay, all those things are more likely to be a calcipenic rickets. Whereas in phosphopenic rickets, they are the most deforming form, especially when, the lower limb deformities. And you may tend to have, dental abscesses, whereas the enamel defects or the caries and those things, are more likely to be seen in a calcipenic rickets. Abscesses are more likely to be in the phosphopenic rickets. And there is severe hypophosphatemia in phosphopenic rickets, and alkaline phosphatase will be much higher elevated in phosphopenic rickets, it can be in the normal range as well. It depends upon the PTH rise and also the vitamin D status. So that is why it is always better to evaluate or do a second evaluation of rickets after correcting vitamin D deficiency, if there is a associated vitamin D deficiency as well. Okay. And the only rickets that has raised alkaline phosphatase or a normal or mildly elevated PTH. Okay, if you are dealing with such scenario, that is phosphopenic rickets. And if you have a rickets with the high phosphorus levels, then it is due to CKD. So the normal values, this again I have emphasized here as well. I just want everyone to focus on the phosphorus levels here. The younger the child, the more higher the phosphorus levels. So even a level that is less than 4 or something like that should make you think in terms of hypophosphatemia, especially at seeing a child with a rickets. Okay, alkaline phosphatase in the range of 350 to 400. Again, like you should be aware about, like, this child, there is a biochemical evidence of, osteoclast resorption is happening. And then normal growth plate, rachitic growth plate. So this again, Mahesh sir has already put. So you need phosphorus for the, the hypertrophic chondrocytes to get ossified. So phosphorus is needed for the process of apoptosis. Once the apoptotic chondrocytes are getting ossified, then the bone formation will happen. So this is the normal growth plate. You can see all the 4 zones of bone growth here. Whereas in the rachitic growth plate, you can see that the hypertrophic zone is like, more predominant compared to the other zones. And the ossification is also less. And this causes the bone to be widened along with other, X-ray fixtures like splaying, fraying, etc. And pointers towards non-nutritional rickets. So this again, I have told you, non-radiological healing after 4 to 6 weeks of optimal treatment. Normal vitamin D levels, but there is a persistent rickets. Hypophosphatemia is out of proportion. Severe deformities and features of systemic illnesses, especially RTA, like, consider in terms if there is an acidosis or something. And family history, consanguinity, and the presence of dental abscess, nephrocalcinosis upon evaluation, and alopecia. You should think in terms of a non-nutritional rickets. So even though like my topic is refractory rickets, I think one has to be aware of the vitamin D dependent rickets as well. There are 2 types, type 1 and type 2. So both can have hypocalcemia. Vitamin D, VDDR type 2 is due to the vitamin D receptor level mutation. Hence, alopecia is more common in VDDR type 2. That also not 100%. Hardly like 20-25% of these children will have alopecia. And all these VDDR type 1 and type 2 both has normal vitamin D, and the differentiating feature is the activated vitamin D levels. So calcitriol levels that will be low in VDDR type 1 and it will be elevated in VDDR type 2 because, as I said, it is the receptor level resistance to the calcitriol. So a physiological response to calcitriol is observed in type 1 and it may not be that easily treatable if it is a VDDR type 2, even with the calcitriol. Higher doses are needed. Okay, moving on to phosphopenic rickets. So it could be lower intake or a phosphate leak due to FGF23 component. Which was, constituently activated or it is not getting metabolized or something like that. And then the third common cause will be renal phosphate leak with hypercalciuria. This is due to the sodium phosphorus co-transporter defect or renal tubular acidosis, distal renal tubular acidosis, and so on, and Fanconi syndrome. So see, this is how the phosphorus metabolism happens. I'm sure the postgraduates will tell what is the first responder for calcium. If there is anything to do with the calcium levels, what is the hormone that comes as a first responder? Sonal, you can unmute and answer. Okay, so that is PTH. Okay, if there is anything to do with the calcium levels, the first responder is PTH. Whereas if anything to do with the phosphorus metabolism, the first responder will be FGF23. Okay, so if there is an increased phosphorus, the FGF23 becomes active and that reduces the tubular reabsorption of phosphorus, leading to phosphorus excretion, thereby normalizing the phosphorus levels. Okay. So once the phosphorus levels are normalized, the FEX gene and the DMP1 and ENPP1, all these genes will try to inactivate the FGF23 so that the phosphorus level is maintained. Okay. Otherwise, the FGF23 is constituently activated. Okay. Right. So as you see in tumor-induced osteoporosis, or FEX gene mutation, which is an X-linked dominant inheritance, where the metabolism of FGF23 is downgraded, and more FGF23 is being in the active form, or it can be constituently activated in autosomal dominant form of hypophosphatemic rickets, or the DMP1 and ENPP1 gene, which again, metabolize the FGF23, can be mutated, and that leads to autosomal recessive form of hypophosphatemic rickets. Okay, so all these things lead to decreased absorption of phosphorus from the renal tubules, thereby causing low phosphorus levels. Now, how to evaluate these children? Like initial investigation should have a calcium, phosphorus, ALP, PTH, and 25-hydroxy vitamin D levels. If you suspect VDDR, or in rare scenarios to differentiate between VDDR and hypophosphatemic rickets, you can get activated vitamin D or the calcitriol levels. Otherwise, it is not needed even in a hypophosphatemic rickets. Creatinine, electrolytes, urine analysis for glycosuria, amino acid urine. If you suspect RTA, you can get it done. And of course, TRP, Sonal has shown a beautiful calculation of how to do tubular reabsorption of phosphorus. So that has to be done in a if you suspect a hypophosphatemic rickets. And urinary calcium creatinine excretion. You can also do a spot urine with the 4 hours fasting, or you can also do a 24 hours urine collection. So this is specifically seen in hypercalciuria conditions, like for example, as I said, the sodium phosphorus co-transporter defect. Okay, right. So hereditary hypophosphatemic rickets with hypercalciuria, that happens in that syndrome, and also in Fanconi syndrome. And then you can do an X-ray of affected bones to follow up on an annual basis, like how significant improvement happens with the effective therapy. Okay, so X-linked hypophosphatemic rickets, I have told that it is FEX gene, it is due to FEX gene mutation, and most likely the lower limbs are predominantly affected. There is delayed dentition and dental abscesses, and there are some extra arthritic manifestation also are there, like deafness, arnold-Chiari malformation, extraskeletal calcification of tendons, ligaments, and joint capsule, enthesopathy, this is called as, and craniosynostosis and raised ICT. Okay. In contrast to vitamin D deficiency, hypotonia and tetany, those kind of manifestations are absent in hypophosphatemic rickets. So this is ADHR is where the FGF23 is being constituently activated. So due to impaired proteolytic cleavage of FGF23, this is a milder variant compared to other forms. Autosomal recessive forms, it is very rare, and they can have arterial calcification as well. And this is due to the mutations in the DMP1 or the ENPP1 gene mutation. And because of this arterial calcification, there can be myocardial infarction and an early death. So investigation, severe hypophosphatemia associated with an elevated serum alkaline phosphatase should raise a suspicion of hypophosphatemic rickets, and renal phosphate wasting indicated by TRP less than 0.86 or 85% or less than that. The formula is given here. This is how we calculate TRP, and it is usually done in 4 hours fasting sample for a spot urine sample, or you can also get it done on a 24 hours urine sample. And then the best indicator will be, tubular maximum reabsorption of phosphorus to glomerular filtration rate, TMP bar GFR. So you have to use the Walton Bijovet pneumogram, and the reference ranges I have given. So you can see that, and any value that falls less than 3 is actually suggestive of phosphorus excretion or phosphorus loss, and that goes in favor of hypophosphatemic rickets. So normal serum calcium, PTH, vitamin D, and calcitriol levels are usually seen in hypophosphatemic rickets. Urinary calcium excretion is also normal in hypophosphatemic rickets. So approach to a child with rickets, I would go first with, instead of doing a calcium and phosphorus, I will try to see it down below. The first thing will be to get an intact PTH level, and then you see with the PTH level. If the PTH levels are in the normal range, then have a look at the alkaline phosphatase. If that is elevated, it is hypophosphatemic rickets. If the alkaline phosphatase is low, then it is hypophosphatasia. If the PTH is increased,
Dr. Divya, sorry to interrupt. We are running quite late.
Yeah.
So
only one more slide I have.
Yeah,
yes.
please.
So vitamin D is in the normal range, then it could be vitamin D dependent rickets. And if the vitamin D is low, then it is nutritional rickets. Okay. So treatment of hypophosphatemic rickets, you need to give an activated vitamin D to promote phosphorus absorption. So that is 30 to 70 nanogram per kg per day divided in 2 doses. Inorganic phosphate, infants require much higher doses compared to childhood and puberty. So the phosphorus sandoz tablet, which is available in the Western countries, it's not available in our country. So we use what is called as the sodium acid phosphate granules, ADPHOS it is called this. And we generally given in the dose as I mentioned in my slide. And also there is Jolie solution, anhydrous disodium hydrogen phosphate oral solution, which is prepared using, if you have a biochemistry lab, this can be done and prepared in your biochemistry lab and given at the biochemistry department, sorry. You can take a screenshot, and because for the want of time, I'm not going into the discussion of how to prepare the solution. The prepared solution, as I mentioned, will contain 50 milligram of elemental phosphorus per ml. And of course, the ideal form of therapy will be, if there is an increased FGF23, you have to kill the FGF23. So you need to have a monoclonal antibody that can block FGF23. So that is burosumab, and the starting dose is 0.4 to 2 milligram per kg. Rounded to the nearest 10 milligram, maximum dose is 180 mg, and it is enormously and exorbitantly costly and not available in India. how to monitor hypophosphatemic rickets. So every 3 to 4 monthly, you do the biochemistry, alkaline phosphatase, phosphorus, calcium, and TRP and PTH. And of course, clinical monitoring of growth velocity. And annually, at least, you should do urine calcium creatinine excretion and then renal ultrasound to rule out nephrocalcinosis. Aim to avoid hypercalcemia and hypercalciuria and secondary hyperparathyroidism and nephrocalcinosis. Growth failure and also to improve the osteoid formation and the things. So there is a role of growth hormone. And orthopedic management can be considered only if there is a good metabolic control. And generally they do osteotomy for severe deformities. Thank you everyone for your patient listening. I will stop sharing. If there are any questions, you can put up in the chat. For want of time, I may answer up in the chats.
Thank you, Dr. Divya, for such a nice and lucid presentation. Thank you. Thank you very much. And thanks, Dr. Sonal and Dr. Salik. So I invite Dr. Medha for OSCE presentation. Before Dr. Medha is Associate Professor at Chacha Nehru Bal Chikitsalaya. Before just being presentation, I want to yes. So we are quite late, so I'm sorry for that. But this was really a nice presentation. So I hand over to Dr. Medha Mittal for her deliberation.
Yeah, a very good evening to all of you. Are you able to see my slides?
Yes, yes. You are audible as well as visible. Yes.
Thank you. So I think our PGs are all set after learning everything about rickets,
Yes.
the forms. So let's go ahead. So we have time of 20 minutes and please answer fast. Okay. The slides. Okay, so this is the first one. A 2-year-old boy came with inability to walk. Weight is less, 7.4 kg, 69 centimeter only. Calcium is 7.5, which is on the lower side. Phosphate is low, 2.2, and ALP is very high, 2242. Can you identify the features, clinical features? Okay, I have told the biochemical problems. Can you identify the clinical features? You can unmute and speak. The participating postgraduates.
Ma'am, you can take the name of postgraduates and ask.
Anksha and Shobit. Vipul.
Yes, ma'am. Wrist widening is very well visible in this, and frontal bossing is there. Bowing of legs is visible.
Yeah, good. So these are all features as you have learned of rickets. So this child was diagnosed as hypophosphatemic rickets based on the low phosphate, and he was started on phosphate. However, there was no improvement after 1 year. So what went wrong? Yes, Shobit. Anyone can answer? Any of the PGs from any institute?
So Dr. Shivangi, you can answer if you are there.
Hello.
Yeah, what went wrong? He didn't improve.
Ma'am, the child also had hypocalcemia with hypophosphatemia. So it was mostly an early age of presentation that goes more towards calcipenic rickets.
Yeah.
So we should.
Correct. That is the answer. So he was not
should
really
get one vitamin D levels. Then. Yes, ma'am.
So he was not really hypophosphatemic. It was a case of hypocalcemic. Okay. So it was a calcipenic rickets. Is phosphate low in all types of rickets?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, good.
Yes, ma'am.
Phosphate is low in all types of rickets. So we'll move on. Who are the PGs from other institutes? Can you please tell your names who have joined?
Salik, you can ask our PGs. So Shivangi, Swastika, I think Shishir is I am able to see.
Okay, anyone else apart from Shivangi? Okay, so we'll move on. So this is a 2-year-old boy admitted for pneumonia. He had delayed motor milestones. Can you identify any features of rickets here?
Calcipenic rickets, ma'am.
Okay, what are the features you can see?
Wrist widening is
Yeah.
pot belly is visible,
Reached
Uh,
Harrison
vitamin.
sulcus.
Pigeon chest is there, ma'am.
Yeah, good.
Yes,
So
ma'am.
now you are good at identifying all the features. So let's move on. So, so this was a case of a calciopenic rickets. And what are the investigations required? As you have, sorry, I've shown it already. Calcium phosphate, alkaline phosphatase, and X-ray. Do we need the entire vitamin D every time? With a
No, ma'am.
picture like
No,
this,
ma'am.
suggestive
No.
nutrition. So these may be enough to go ahead. So what is the earliest biochemical change after treatment? Sorry.
Increase in phosphorus.
Yeah.
Increase in phosphorus levels.
Phosphorus
Okay.
levels.
So this is an X-ray of the child. Can you identify the X-ray changes?
Yes, ma'am.
There's cupping, splaying.
Spraying and splaying is visible.
Yes, ma'am.
Okay. So what is this fraying? What is fraying? Akanksha, what is fraying?
Ma'am, the ends, the metaphyseal ends,
Yeah, the irregularity of the ends.
irregularities.
So what should we give? Should we give active vitamin D? We want to have a quick improvement. Should we give active vitamin D? 1 alpha?
Yes.
Should we give?
No, ma'am.
Why?
No, ma'am.
Why should we not give?
Because the
First, try
pathway is
normal
not.
vitamin D with calcium supplementation. Wait for 4 to 6 weeks for improvement. If it is
Yeah,
not
yeah.
improving, then you should
I'm
work
very
upon.
fast. No, I want to have quick improvement. I want to give active vitamin D. What is the problem?
Ma'am, half-life of the active vitamin D is very
Yes.
less. Yes, ma'am.
Yeah. Okay, so that half-life is very less. So only it should be used only if there are persistent seizures with hypocalcemia and
Yes,
not
ma'am.
improving. So for a short time, you may give for initial 2-3 days.
Yes, ma'am.
Okay, next one. So this is a 28-month-old boy, okay, presented with inability to stand without support. Both the parents were supporting from both hands. So I'm just showing you the pictures of the lower limb. So and he came with short stature. Already received 2 doses of injectable vitamin D, 6 lakh. And apart from calcium, for last 6 months receiving calcium. No history of patchy hair loss and no history of any jaundice or malabsorption. Anyway, he received injectable vitamin D, so even that malabsorption was counterfeit. And he has a history of 3rd-degree consanguineous marriage. Weight and length are both low. And you can see from the calcium and the phosphate parameters, calcium is 7.3, phosphate is 2.3, ALP is 2327, PTH 398. What do you think is the issue?
Most probably
VDDR
1
type
alpha
2, ma'am.
Oh my God,
One
you reached the molecular diagnosis. So you can see the X-ray also, you can see multiple fractures here. Okay. And even here, you can see the changes of rickets and you can see fractures in both humerus. So what do you think it is? It is a vitamin D deficiency rickets? Do we have
Yes, ma'am.
Srinivas or
Ma'am,
Srikant?
receptor problem.
Huh?
And there is receptor
Calcipenic
problem, not
repair.
bro.
So all of us agree that it is not nutritional rickets, right?
No,
Yes,
no,
ma'am.
no.
Yeah. So because the child has already received vitamin D and the child has received injectable. Okay. So even the gut has been bypassed, the vitamin D has gone, but it has not had any improvement. So it is not
Receptor mutation, ma'am,
deficiency.
type 2
So it
vitamin D
is
dependent rickets.
similar
Because
to
both
vitamin D deficiency rickets, but without improvement on vitamin D, right?
Yes, ma'am.
The clinical and biochemical picture is similar to vitamin D deficiency rickets, but without improvement. So it is something to do with the vitamin D metabolic pathway. Okay. So this was the X-ray bigger view. Even the femur was having fracture here, and you can see the bowing. So what are the differential diagnosis? As you said, any
type
other
2
differential
VDDR.
diagnosis?
Sir, ma'am, VDDR, skeletal dysplasias, OI.
Yeah, yes, great. So VDDR, skeletal dysplasia or OI, or maybe we can do an VBG to exclude RT. So what are the pointers towards the diagnosis?
Ma'am,
Dr.
low
Shivani,
calcium.
Dr. Shishir?
Ma'am, calcium is low, both vitamin D 25 and 25 are elevated despite treatment, which means even though we are giving appropriate therapy, there is no response, which means
Correct.
the action is not happening in the cellular level. So
Great.
VDDR type 2 is our first diagnosis, followed by skeletal dysplasia or OI with other features we have to see, followed by RT.
Oh, great. Let's see. So it is similar to vitamin D deficiency rickets and a high PTH. So it is a VDDR. So what is the enzyme defect in VDDR1?
1 alpha hydroxylase.
1 alpha
Hydroxylase
hydroxylase deficiency.
Yeah, it could be 1 alpha or 25. 1 alpha is more common. Okay, and what is defect in VDDR2?
25
Receptor.
hydroxylase. Right.
So
And
capital
receptor
is a receptor.
And receptor.
Okay. Yeah.
VDDR
Receptor
type 1
interaction.
type 1A and 1B में
VDDR
1A में
1
1 alpha hydroxylase, 1B में 25 hydroxylase, 2A में there will be receptor deficiency, 2B में there is signaling deficiency,
So receptor defect is more
3 में
difficult to
overactivation.
manage and more rare. So this was actually a case of VDDR 1. What is the treatment plan?
To give active calcitriol, active vitamin D.
calcitriol supplementation along with calcium.
Yeah, great. So we went ahead and gave active vitamin D here. Because the 1 alpha action was not there, so we gave activated. So a 9-year-old boy, the fifth asking, 9-year-old boy presents with progressive deformity of the lower limbs since early age, and he has also received multiple courses of vitamin D without improvement. As you can see, his height is greatly affected. It is at minus 4.2 standard deviation. So what questions do we ask in history to differentiate between calciopenic and phosphopenic?
Some dietary history, family history,
Okay.
like similar complaint in the family, or what are the dietary history of the patient? Despite
History of bone pains.
Exactly, yeah.
So,
So calciopenic, as you have heard till now, so any history of bone pains or not
Dental
really bone
abscesses.
pains, pain on walking, as she said, and
Generally lower limbs are more affected, and then dental abscesses.
yeah, in phosphopenic, in the
Yes.
hypophosphatemic. What
Yes.
else? There can be seizures and tetany also, no?
yes.
Calciopenic. That will actually point to a reduced calcium, right? So what are the expected biochemical findings in this case now that you are suspecting hypophosphatemic? Shishir
Levels
Shiva.
of phosphate with near normal values of calcium, PPH.
Yeah.
And raised ALP.
Yeah, raised ALP is there. So calcium normal, phosphate low, ALP high, and PTH is normal. Why is the PTH normal?
Because this is a
Calcium.
calcium,
Yeah.
not
Calcium is
phosphate.
normal, ma'am. That's why
Yeah.
the PTH is normal.
Exactly.
Yes, ma'am.
Okay, and otherwise PTH increases to decrease the phosphate. Here the phosphate is already low.
Low, yes.
So what is the cause of low phosphate?
Phosphaturia, ma'am.
Phosphaturia.
Why is the phosphate low?
Because of
Ma'am, FGF 23 will make the
excess levels of
Yeah.
FGF23.
FGF 23
FGF23 is
will
phosphatonin, which
phosphaturia.
excretes
Yes,
the
ma'am. Phosphate from the
phosphate
urine.
from the body. How does it excrete?
By causing
Excretion from the kidney.
Wow. It causes excretion of phosphate, or what does it do? It
It
actually
affects the reabsorption from
it
the
affects the reabsorption of phosphate. So reabsorption doesn't occur. What is the receptor for reabsorption?
and TB2B something.
Yeah. So that receptor is
P2A and
internalized. So that receptor is internalized. So there is more excretion, high FGF23. What is the characteristic finding we should look for in oral cavity?
dental abscesses.
Yeah, periapical
Dental caries.
abscesses. What is the inheritance of this condition with high FGF23?
X-linked dominant,
Like in this
X-linked
boy?
dominant.
Huh?
X-linked dominant.
X-linked dominant.
Linked, autosomal recessive, autosomal
Autosomal dominant, yes,
All
ma'am.
three are there.
Yeah.
Most common is X-linked.
Most common is X-linked dominant.
Yes,
Yeah,
ma'am.
the effects will come from X-linked dominant, right? If the mother is affected, is the mother equally affected or less severely affected?
Less severely affected.
Less. Why?
Because it's an X-linked disease, so
So the
males
boy
are
is
generally
affected more,
more.
right? What are the X-ray findings in hypophosphatemic rickets? Is it different or is it exactly same?
There will be more lower limb changes, ma'am.
Yeah, very good. What else?
Mhm.
When we take the X-ray,
Bowing and fractures may be seen more frequently.
so there is increased cortical bone thickening and coarse trabeculae. So you see the PTH is not increased, so there is less evidence of osteopenia.
Yes, ma'am.
Okay, and the wrist changes, the splaying and fraying are also less. Okay. So the more bowing, increased cortical bone thickening, less of osteopenia and coarse trabeculae. So this was actually a case of X mutation and X-linked dominant, and mother was also affected. Okay, next case is 6-year-old girl presented with progressive deformity of lower limbs. Okay, received 3 courses of vitamin D. Calcium is 9.1, phosphate 2.1, ALP 728. Blood gas was normal and normal potassium. We did a fractional excretion of phosphate and it showed increased phosphate excretion. Diagnosed as hypophosphatemic rickets. Do you agree?
Yes, ma'am.
Yes, ma'am.
Okay, so what is the expected PTH?
PTH will be normal.
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 Normal, ma'am.
What is the expected?
ma'am.
125. In hypophosphatemic with FGF23 increased, what is the expected 125?
1,
It should
25 will
raise.
also be
It
normal.
should raise, ma'am, but it would be
It is
low
going to
between.
be reduced.
Yeah, what does
Ma'am,
FGF25, FGF23 do apart from
It
Ma'am, it
inactivates 1 alpha
it
hydroxylase.
inhibits 1 alpha hydroxylase, so
Great.
That is why 125 is going to
125
be
will be
low.
low.
Yeah. So expected PTH is normal and do we, yeah, inappropriately low or normal because otherwise if the phosphate is low, usually 125 will try to increase so
Yes.
that increased absorption from intestine can happen. But in this, because of the FGF23 being high, it inhibits the 125. Okay.
Yes, ma'am.
What is the important test to be done before you start the treatment? Because we are actually not testing at the
FGF23 levels, ma'am.
but it is not always available to us and the mutation study will not come immediately. So what is one test you must do before you start treatment?
Levels of 125.
Okay, anything else?
serum phosphate.
We should do test for urine calcium because there is one form where the 1 alpha activity is preserved. There is a separate mutation where the 1 alpha is preserved and there is NAPI2C is affected, which is
Hypercalciuric. Yes.
hypercalciuric variety,
Yes,
which
ma'am.
also causes
Yes, ma'am.
hypophosphatemia, but also causes hypercalciuria. So we must exclude that before we start treatment. So urine calcium to be done before you start treatment. Of course, you will send urine for phosphate. So at the same time, you send urine for calcium also. Should we guide the treatment by serum phosphate?
No, ma'am.
Oh, ma'am.
Should we try to normalize the phosphate? No.
ALP
No.
should be targeted.
Yeah. So we should not guide the treatment by phosphate. So what to do if there is high PTH during treatment of hypophosphatemic rickets? So we are not guided by phosphate. So we are taking ALP and PTH for our guidance. So if the PTH is high, what do we do? When does PTH increase? When there
If
is more
calcium is
Calcium is.
Check the
Calcium will fall.
calcium is low, but in this case there is calcium is normal.
Hmm.
What is the other stimulus for phosphate to increase, for PTH to increase?
And phosphate increase हो
To
जाए.
wait
phosphate.
on
Yeah.
phosphate.
So if the phosphate is more, the PTH will increase. And what do we give to keep the PTH low?
Calcium.
Calcitriol.
Sorry?
Bisphosphonates.
Calcitriol.
Calcium.
Calcitriol. Yeah, that is the purpose of giving calcitriol. So if the PTH is high, this means our phosphate and the phosphate you document as increase. So we should decrease that time phosphate if the child has been taking more. If the ALP is high during treatment, ALP is a marker of healing. So if the ALP is high, this means what should we do? We see if the child is actually not compliant with treatment. Okay, he should take more phosphate or he should take in small doses throughout the day. If there is hypercalciuria, because we are giving 1 alpha also, so if there is hypercalciuria, either we reduce the 1 alpha or what else? What can we give? So anything to reduce hypercalciuria?
Thiazide diuretic.
Thiazide, great, good. So if there is inactive vitamin D, inactive treatment with inadequate treatment with active vitamin D, and there is persistent secondary hyperparathyroidism, then what can we give? Any newer drug to suppress the PTH? So we can give calcium mimetic.
Teriparatide.
Okay, next. So a 16-year-old boy was playing football with his friends. So because we are having rickets and bone mineralization both in this PEP. So a 16-year-old boy was playing football with his friends and he had a fall and fractured his tibia. His mother insists that we must get a DEXA done for bone strength. She has talked to her friends and she says that we must get DEXA done for my child. Is she justified? You'll go ahead and order an X-ray. Sorry, order a DEXA, Dr. Shivangi.
No,
Dr.
ma'am.
Ritu? Sorry?
No, ma'am.
No. Okay. So why are adolescents more prone to have fractures? Anyone? Dr. Shishir, Dr. Swastika, Srinivas. So you see there is increased length.
Delayed mineralization due to rapid bone growth, ma'am.
Before the strength can increase, there is increased length, so the bones are more prone for fractures. So what are the indications? When will you actually assess for bone fragility?
Recurrent fractures more than or equal to 2 long bone fractures more than less than 10 years, more than or 3 long bone fractures after 19 years, or vertebral compression fractures, ma'am.
Great, great. So even any one vertebral fracture or two before 10 years and three before the age of 18 years to assess for bone fragility disorders. So which of these mentioned hormones has a negative effect on bone formation?
Pyroxine.
Cortisol.
Cortisol.
Yeah, you are giving steroids for nephrotic, so we must think of this. What is the mechanism? So it inhibits calcitriol production and decreases the osteoblastic activity while increasing the osteoclastic activity. So last one. So this is a 6-year, 10-month-old boy, limb deformity since early childhood and progressive, showing to practitioners, various practitioners not getting good treatment, already received 2 courses of oral vitamin D. Non-consanguinity, no similar history in siblings, and on further history we find there is increased urine frequency and volume. You have the biochemicals in front of you. Anything you see from calcium phosphate, alkaline phosphatase?
Hypokalemia.
Yeah, only there
Hypokalemia,
is not
hypocalcemia.
there is hypokalemia and ALP is just, mildly increased. Phosphate is on the lower side, 3.3. So weight is 19 kg, minus 0.5, and height is severely affected, minus 3.7. What else do we do?
Ma'am, VBG.
Okay, great. Anything else?
RTA.
So VBG is done.
VBG.
pH is 7.2, bicarb is 10. Urine pH is
RTA.
6. Great. So let's go ahead. So what are the differential diagnosis?
RTA.
What? RTA, because you already have the blood gas. So which further test to be done after blood gas?
Urine pH.
PTH.
pH is done.
Urine anion gap followed by
Anion gap. Okay. So what is the
Anion
formula?
gap.
bicarb loading FF test based on the type 1 or type 2 RTM.
Yeah, so fractional excretions. The urine anion gap, what is the formula?
Sodium plus potassium minus chloride.
Yeah, sodium plus potassium minus chloride. How do we differentiate between proximal and distal?
Urinary pH is more than 5.5 in distal.
Hmm.
And amino acid urea and all these are present in proximal.
Proximal.
Glucose urine. Yes, ma'am.
Yeah. Distal is more likely to have hypercalciuria.
Yeah.
And very important thing you saw on the biochemical,
Proximal.
hypokalemia. Okay. So hypokalemia at presentation, as sir always says, that hypokalemia at presentation is more likely to happen in distal. Okay, while in proximal, when we start the treatment, the child may have hypokalemia after initiating bicarb. You see, in the proximal, it is fractional excretion of bicarb is affected, it is excreted more. So after we start bicarb, the bicarb and the potassium will be internalized and the potassium will be secreted and H plus will be internalized. So hypokalemia at presentation is a sign of distal RTA. Okay. So thank you very much. This is my last slide.
Thank you, ma'am, for the lucid presentation, and you have covered all the aspects which we wanted to cover. So all the PGs have participated actively. So now I am quickly going to share the questions which have been asked in previous exams. So we will just wrap in 5 minutes. So all these topics have been discussed in detail. So you must be able to answer all these questions. So is my slide visible?
Yes, it is visible. Yes.
So most of the questions are based upon the calcium metabolism. So, like discuss the metabolism of vitamin D, parathyroid hormones, some clinical based questions like child presenting with deformities, outline the synthesis of vitamin D, causes of rickets, and the investigations which are required in resistant rickets and hypophosphatemic rickets. And then there were questions on the bone mineral disease um, uh, in relation to chronic kidney disease, features of hypocalcemic tetany in a neonate, describing the causes of hypocalcemia. And there was another question regarding the case scenario, like 2-year child with low phosphate, normal calcium, and high alkaline phosphatase, and PTH was normal. So, what was most common diagnosis, pathophysiology, and the outline, the management. Some other questions, short questions of 5 marks, like clinical manifestation of rickets, vitamin D, vitamin D resistant rickets, renal rickets. So all these questions have been asked. So most of these aspects we have tried to cover in both the lectures by Dr. Mahesh and Dr. Divya Lakshmi. And Medha ma'am has asked what you have learned. So most of the questions are pertaining to the calcium and vitamin D metabolism, and some questions are related to tetany, hypocalcemia, and the neonates. And few questions on the osteoporosis. Those are in the recently. And sometimes they ask the newer drugs. So burosumab is the newer drug which has been used for hypophosphatemic kids. So I will say these questions in the group, so you can go through it, but most of the aspects we have covered. So now I hand over to Dr. Vijay for the vote of thanks.
Yeah. I really enjoyed today's talk, and thanks to all the presenters, their mentors, and the faculty for doing the justice. And I'm really thankful, and we promise that we are going to increase much more relevant topic again in the coming presentation. So thank you so much, and thank you Anurag sir for your gracious present. So a word of concluding remarks from your side, sir.
Thanks a lot. It was a wonderful program. I'd like to really congratulate both Professor Vijay and Dr. Javinder for really coordinating this. Dr. Divya Lakshmi, Dr. Mahesh, Dr. Medha for having such a wonderful interaction. I think this is one of the most important topics from not only the PG exam perspective, but also from a pediatrician perspective. So I hope all of you have learned a lot about calcium phosphate metabolism. And thanks all of you again on that. Yeah. Thank you.
Thank you. Thank you all.
Thank you. Thank you, everyone.
Thank you, everyone. Thank you, sir.
Somebody has asked the slides are not visible, but the video of this session would be available on the ISPAE's YouTube channel. So you can revise through that tube video.
Okay.
Thank you.
Okay, thank you.
Thank you, sir.